Good evening, everybody, and welcome to the DeBakey CV Live series. I'm Arvind Bhimaraj. I'm an advanced heart failure specialist and the interim division chief of the Division of Heart Failure at the DeBakey Heart Center here at Houston Methodist. I'm very excited today to announce that as a part of the Methodist CV Live series, we're starting a heart failure hour, an hour of discussion on heart failure. And as all of you realize, heart failure has become a multidisciplinary complex field that we're hoping by discussing various topics related to heart failure, we'll be able to engage in conversations with experts and hopefully educate the world about heart failure. Today, my co-host and our guest here are here to talk about one of the really an exciting area of heart failure, and also a focus on what we're calling as diabetocardiology. Imad, if you can go to the next slide up there, and then we'll introduce our guest. Before we go on to today's topic, I want to point out that please make note of the monthly series on various topics, related to heart failure, ranging from the current COVID-19 crisis to cardiac amyloidosis. So we hope all of you can join us on these dates to engage in discussions on heart failure. And Dr. Hussain, who's here with me, who's my co-host today, essentially he is overseeing this series and has put together a good plethora of topics. And to quote Dr. Braunwald, it's really come a time where endocrinologists and cardiologists are getting together and facing the challenges of knowing each other's field with the birth of what he called as diabetocardiology. And we'll learn more today in detail about what these interactions are, how we've known about the impacts of heart failure on diabetes and diabetes on heart failure and medications. But it's become a really exciting area. And with no further ado, I want to introduce my partner, Dr. Imad Hussain, who's my co-host and essentially the focus on diabetic endocardiology has been in his area of interest. Dr. Hussain is the Associate Director of our fellowship program and has a keen interest in education, and he'll introduce our guest today, Dr. Dale Hamilton. So Imad, to you.
Good evening and welcome to the Heart Failure Hour. I would like to take the privilege to introduce our esteemed speaker, Dr. Dale Hamilton. Dr. Dale Hamilton is the Director for the Center of Bioenergetic Research at Houston Methodist Research Institute. He is also a Department of Medicine, Endocrinology and Diabetes faculty consultant. He is the Elaine and Marvie Finger Distinguished Endowed Chair for Translational Research in Metabolic Disorders. He is a full clinical member of our Research Institute and Professor of Clinical Medicine at HMAI and WCM. So with no further ado, we would like to get into this topic, diabetes and heart failure, and talking about the novel use of some anti-diabetic drugs in heart failure. To set the stage for diabetes and heart failure, I would like to go over some of the interactions of diabetes with regards to heart failure. So when you talk of diabetes as a risk factor for heart failure, if you look at the Framingham Heart Study, diabetes was associated with a nearly twofold increase in the risk of incident heart failure in men, but even a higher fourfold increase in women, even after adjustment for conventional cardiovascular risk factors that we usually talk about in terms of heart failure. And this risk was even further amplified, particularly in younger adults, as you can see here. This is just a depiction of that. Another interesting thing is that diabetes is a spectrum. I mean, there's a control going from a hemoglobin A1C of 6.5 to over, say, 9 to 10%. And you will see that for each 1% increase in hemoglobin A1C, the relative risk of incident heart failure increases by 30%. So what about the pathophysiology? How does diabetes cause heart failure? Well, on the left, you see here in red, is the conventional way we think of diabetes as a cardiovascular risk factor for CAD in terms of causing atherosclerosis, inflammation, endothelial dysfunction, and hyperlipidemia that down the road will lead to coronary artery disease and eventually culminate in ischemic cardiomyopathy. That is the conventional route. But then there's another route that leads to something called diabetic cardiomyopathy. And so if you look at diabetes, it is a state in which there is hyperglycemia, there is hyperinsulinemia, and there's insulin resistance. Because there's lack of glucose oxidation, there's increase in free fatty acid oxidation. And this increase in free fatty oxidation and decrease in glucose oxidation can result in lipotoxicity to the cardiomyocytes. Secondly, hyperglycemia can lead to accumulation of advanced glycosylation end products. And this downstream can lead to remodeling of the heart, in particularly with regards to myocardial fibrosis. Diabetes, like other comorbidities, like chronic comorbidities, is also a pro-inflammatory state. And as you can see that it can increase fibrotic and pro-inflammatory cytokines, again leading to ECM remodeling and downstream fibrosis. This inflammatory process will also increase the generation of reactive oxygen species that can in of itself cause myocyte damage. And the culmination of this will be myocyte apoptosis, fibrosis, and LV concentric hypertrophy. So the first manifestation of diabetic cardiomyopathy will in fact be diastolic dysfunction, but if left unchecked, can then lead to systolic heart failure. So in essence, diabetic cardiomyopathy is defined as the presence of a diastolic or systolic dysfunction in a patient with diabetes without an other obvious cause, for example, CAD, hypertension, or valvular heart disease. A little bit in the end about impact of diabetes on the heart outcomes in heart failure. So if you look at population-based studies, if you have diabetes as a comorbidity in heart failure, it increases the risk of death both in hospitalized and ambulatory patients with heart failure. The risk of heart failure hospitalization is up to 50% higher in patients who have diabetes than in those patients who have heart failure but do not have diabetes. Patients with diabetes have definitely a worse health-related quality of life as assessed by various questionnaires. And this effect is not only in heart failure with reduced ejection fraction, but it's also with heart failure preserved ejection fraction. So as you can see in this slide with the I-PRESERVE trial, looking at the primary outcome of cardiovascular death or heart failure hospitalization, when you look in red, it's diabetes, and blue is no history of diabetes. And you can see the composite endpoint is significantly higher as opposed to patients who have heart failure but do not have diabetes. So this effect on outcome is both for heart failure with preserved and reduced ejection fraction. So with this, I would like to turn to Dr. Hamilton, who is an expert endocrinologist, and ask him, so Dr. Hamilton, please tell me, what drug classes are you going to be discussing today, and can you give us cardiologists an overview of the anti-diabetic drugs?
Yes, and I would like to thank both of you for this invitation. It's quite an honor to be able to come here and discuss this with you. Not as a cardiologist, but as an endocrinologist. But an endocrinologist who has an interest in metabolism and the impact of metabolic changes, as with diabetes, on the heart. In fact, I've transitioned, as you know, into laboratory and clinical work, looking at mitochondria, energy transfer, and abnormalities in patients with diabetes and without diabetes in high energy organs like the heart. So it's with that background that I'm really pleased to at least talk about some of these new therapeutics, which are shifting from the endocrine world to the cardiology world. And in just a brief presentation, I just want to emphasize which drugs, which medications are the ones that you as cardiologists will probably be prescribing more than us. There's just not enough of us endocrinologists around.
If I may take the liberty, I think as you mentioned, you could be the first diabeto-cardiologist because you're a diabetician who's worked a lot in heart failure. And I think I want to tell the world that we've shared laboratory work in mouse models, and Dr. Hamilton's done phenomenal work in studying the metabolism in the myocardium. So for our luck, you're interested in the heart, and being a diabetologist, you're perfect for us to get an overview from. Thank you for being here.
Yeah, it's interesting in the research world. Often in the research world, rarely get asked why, as an endocrinologist, I'd be involved with the heart, because it's such a challenge metabolically. But in the clinical world, they wonder, well, why does the cardiologist deal with it? But we get all these hallway questions now on these new medications. So I want to just give a brief presentation to summarize what we're talking about here, and maybe help with this transition. So let's see. I'm not sure how
I think here.
Thank you. Just have no conflicting interests, clinical trials or sponsored trials involving these cardiac medications. Just wanted to make that clear up front. And as an endocrinologist, and we train our fellows and other endocrinologists on these 9 classes of non-insulin diabetes medicines that are becoming a challenge for us to keep up with. Let alone non-endocrinologists and diabetes specialists. There's 9 classes there, and about at least 6 of those classes have had some challenges when it comes to cardiovascular outcomes. TZDs, for example, increase in the risk of heart failure. But since 2014, 2015, the last 5, 6, 7 years, things have changed considerably. And for that reason, I want to focus on this last class, SGLT2 inhibitors, gliflozins as they're called. And but I'm also put asterisk there by 2 other classes that may complement or play a role or offer an alternative treatment too, that are showing some benefit, maybe not to the scale of the SGLT2s, but some benefit to heart failure outcomes and hospitalization rates in individuals with and now without diabetes. This is at first glance, kind of a complicated slide, but I just wanted for the cardiologists that in this class, that last class, the SGLT2 inhibitors, there are 4 agents, and gliflozins, as they're called, and they each come with 2 strengths. Now, most of the effects of this and the benefits on heart failure, outcomes, hospitalizations are probably class specific. But the strongest evidence is in the middle 2 there, the dapagliflozin and empagliflozin from the trials involving those 2. But canagliflozin has had ongoing trials that are supportive of this too. And the last one that's still, it's a little bit weaker in the one trial that they've come out with the steglitrol. And so, although I wouldn't emphasize one over the others, I think there's a class effect, but these are all beneficial in individuals that have heart disease with or without diabetes. And this recent, there's these recent findings of this favorable outcomes in those without diabetes really makes us think that this may not be related to the improvement in glucose control and the metabolic effects of this. But one thing to keep in mind if you're going to be prescribing these is that you need to watch renal function there. And a lot of individuals with advanced heart failure are going to have eGFRs under 30. And this as a class, at least today, they're contraindicated. And if they are between 30 and 60, and you initiate the therapy, it's important to watch. And if it falls, say if it goes from 55 or 60 and falls into the 45 range, it's recommended now, at least, that consider stopping it and transitioning to another metabolic therapy. but if it's holding steady and they're already on the medication, their EGFR's 40, they've got CKD, and it's stable, then continuing it. So the mechanisms of these, and this is just a quick overview here, are mostly speculative. We do not have strong laboratory evidence. It's some of what we are looking at in our own lab in the preclinical models. And I've cited a recent, very excellent review article there, published in the Journal of American Heart Association, that goes over this. And obviously, there's a lot of talk about the osmotic and natriuretic effect of these because you're losing the glucose and sodium at the renal level, volumes decreasing, and blood pressures are coming down, that maybe it's a hemodynamic effect. But I think it goes beyond that, and the glucose control is improving, but it's more than just metabolic, at least glucose control affected. There's evidence now of effect on endothelial function. There's a rise in H&H, the erythropoietin excretion. But obviously, from my background as an endocrinologist and what we do in my lab, looking at energy transfer, improved myocardial energetics is what intrigues me. And if we're trying to get evidence in support of this, that there's a switch, of course, glucose is a favored fuel for a high energy organ like the heart. But in fatty acids, as you mentioned, long chain fatty acids could accumulate in the heart and back it up and have an unfavorable effect on a cardiomyocyte. But these agents as a class will increase circulating ketone bodies. And ketones are high energy fuels. It's like a high octane fuel going to, I'm thinking, to the heart. We're trying to prove that in the lab, that it bypasses beta oxidation. And I don't want to get into details, I mean, it's not a research conference, but of the possible mechanism, that's the one that's kind of got my attention. And these documented adverse effects, so if you're going to be prescribing these and following up, is there's urinary tract infections. And we see that a lot. They're usually mild. Bladder, they can be in the kidney. Still a small percentage, 1 to 2%. And genital infections, often which can be treated topically in men and women. But there's rare cases of this Fournier's gangrene, which is quite serious. It's a necrotizing fasciitis in the groin and inguinal area. It's quite rare, even with these medicines, but it's something to watch for. And of course, because ketones are being made, and I think they're favorable to the heart, if they start piling up, you can get this so-called euglycemic ketoacidosis. Because the blood sugar is not high, but they're getting acidotic, and the lactic acid may not be elevated. Hence, in an early, one of the first trials to come out, the Canvas trial, showed that there was a slight increase in lower limb amputations. It put a little bit of a negative on canagliflozin, but later trials have not supported that. And there may be a subject selection and so forth, but it's a medication that's getting stronger and stronger evidence, along with the empagliflozin and dapagliflozin. So there's trials now that in the last year or two that really caught us off guard, that it's benefiting people that do not have diabetes, and hence the diabetologist may not be involved, and the cardiologist, and will end up prescribing and managing these. I think it's a class of drugs that y'all are going to have to get quite familiar with, and they'll feel comfortable prescribing and having something to monitor on them. Of note, though, we've had several instances where the medication was started, the patient's discharged from the hospital and they come back, and they see their follow-up doctor, primary care doctor, and they'll say, well, you don't have diabetes, you can't be taking that. Or the insurance company may stop. And then they'll have a follow-up with the cardiologist 2 or 3 months later, and they've been off of the medicine for 2 months. So just like to emphasize, you start using more of this in non-diabetes, communicating to the other care providers and working with that and making the patients themselves aware that this is beneficial, even though it's a, quote, diabetes drug. The FDA has approved beginning to approve them now for those without diabetes. So just want to give that overview of that particular class, because it's really changing the treatment options and the relationship between the diabetes and endocrinologists and cardiologists, especially the heart failure cardiologists.
Dr. Hamilton, I think two key points that you referred to, I want to highlight to the audience, and I had to remind myself too, is when we think about diabetes and heart disease, we end up thinking a lot about ischemic disease and MIs, which I think is a significant interaction, but this whole class of medications are reminding us that it's not just about the sugars, but there's some metabolic derangements that happen, and that speaks to all those studies which showed tight glycemic control by itself doesn't create good cardiovascular outcomes. And I think that's something I feel we forget sometimes, and as much as ischemic disease is important to focus on, the fact that the diabetes is causing a metabolic derangement, and a lot of the medications historically might not have addressed this, I think is kind of this whole fascinating area that's coming up.
Yeah, that's a very interesting insight into it. Is that people question, is there a diabetes cardiomyopathy or not? You know, but there's a metabolic cardiomyopathy. I don't think there's any question about it.
And one practical question about prescribing the medication, because as you said, we as cardiologists are trying to get more comfortable with the medications which are diabetic medicines. A lot of times we work with endocrinologists, we push for HbA1c goal, but not really adjust things so we're not overstepping the boundaries. As we're prescribing these medications, because now you have an FDA approval for heart failure indication primarily after the DAPA-HF trial. So in specific to the UTIs and the lower extremity abnormalities and the other medications, what do you advise the patients to do when we start these medicines? Is there an extra vigilance you ask, or do you check a UA frequently? Is there any practical tips you think we can come up with?
Yeah, I think early on, checking, doing urinalysis and making them aware and to report any symptoms of urinary burning or frequency and or rashes that are breaking out in the genital area. But probably more importantly, more common and more serious potentially is a buildup of ketones and this euglycemic ketoacidosis. Even mild cases of it in the setting of individual with heart failure could trigger arrhythmias or hypotensive episodes. So relatively frequent monitoring of even a BNP, the electrolytes, and looking at the anion gap. You see that CO2 going down because their A1Cs and glucoses aren't out of control if they don't have the diabetes, you know. And periodically measuring beta hydroxybutyrate in addition to lactic acid to watch for it. Because it's a reality. And we see in the hospital here, of course this is a tertiary care, high frequency hospital, and we see a fair amount of this so-called euglycemic ketoacidosis. They're not type 1 diabetes, and they get, some of them, severely acidotic. So I think that's the biggest red flag right there.
No, that's good to know. I think, Imad, you're going to go into the mechanisms, so that might talk about what else we could do for monitoring and practical tips.
Yes, I mean, one thing, just adding to your point, would be that when we have been prescribing as cardiologists, we are typically starting at a lower dose, the 5 milligram dose, because our patients are typically on also Entresto, which also has a natriuretic effect. We, in our experience, we've been actually cutting the diuretic dose a bit for patients who are on DAPA, anticipating the osmotic diuresis. And then also we have been reaching out to the endocrinologists to see if we can reduce the insulin dose. But I wanted to ask you, is that a good thing to try to do that, or does that increase the risk of DKA? So the question I have for
on
you.
the diabetes patient, that's a very good point, because that's part of the argument that by reducing the insulin dose too, you're going to increase the risk of the acidosis, the ketoacidosis evolving. So you got to be very careful about it. because these medicines do not cause hypoglycemia. I mean, if you don't have diabetes, or you can take them. I think they'd like to use them for weight loss medicines, since most individuals lose 3 to 5 kilograms of weight, even though they're urinating more frequently without getting hypoglycemic if they don't have diabetes. But yeah, reducing that insulin dose. But it's starting, like the I think it was the DAPA-HF trial. They were using a 10 milligram dose.
Yes.
And most of the others, they might have started with the lower, like canagliflozin of 100, but then they quickly went up to 300. And a lot of them, almost all of them, they end up on full dose.
Yes.
And the only reason to start it lower, maybe just because they might get urinary frequency and let them adapt to that, and they might get rid of some extra body fluid that way. And as the glucose comes down, then advance it up. It's just transient.
We've had some patients who had developed hypotension after starting the 10 milligram dose straight. So is that something you think is common or probably uncommon?
No, most of the trials they did, there was a drop in blood pressure and a transient rise in creatinine, which was an early concern. But it's just transient, and within a short period of time it recovers. And now there's evidence with canagliflozin that and probably as a class, there's going to be renal protective effects on this. They may now become a treatment to help CKD, and nephrologists are starting to use it more.
Yeah, absolutely.
Because the DAPA CKD trial was stopped early because the Safety and Data Monitoring Committee essentially saw that the benefit was so exponential that they stopped the trial as an early. So the results are not published, but the outcome in that trial was a drop in GFR 50%, and they saw phenomenal benefits. Yeah, I think it's a fascinating mechanism. So maybe Imad can go over that, and we'll come back to some practical discussions.
So for the audience, we just wanted to, before we get into the a little bit deeper into the SGLT2 outcome trials, and in particular the DAPA-HF trial, and some insights into the mechanism of action, because it's an anti-diabetic drug, but it seems to be working in heart failure with or without diabetes. Before getting into the mechanistic insights, just for the audience, wanted to just very briefly go over some of the other anti-diabetic drugs to give you some understanding when you're managing heart failure patients. What does it mean for them to be on some of these other medications? Because as you see, as you're going to be managing them, you'll see patients on various types of anti-diabetic drugs. So starting from metformin, it's typically considered first-line therapy, and there is observational data actually that suggests that there's a survival benefit in heart failure patients. The important thing is it's contraindicated with the eGFR less than 30. This is what I'm hinting towards. There was a trial out of the observational study out of the VA hospital that showed that patients who were discharged on metformin had reduced heart failure hospitalization and reduced death compared from heart failure. If you look at the sulfonylurea class of drugs, there are several observational studies that have suggested that sulfonylurea drugs may be associated with increased risk of heart failure events when compared with metformin or some of the newer anti-diabetic drugs. There are no randomized controlled trials that examine their effect on clinical outcomes. So basically, on the basis of the available data, use of other agents such as metformin or SGLT2 inhibitors that Dr. Hamilton so deeply talked about is preferable in place of sulfonylurea drugs in patients that are either at high risk for heart failure or who already have heart failure. In terms of insulin, there's only one randomized control trial that assesses the cardiovascular safety of insulin. That was the Origin trial, and that was using insulin glargine versus standard care. And that did not show any difference in cardiovascular outcomes, and that included heart failure hospitalization. In fact, there was some observational data that suggests that there is slight increase in heart failure with insulin therapy, but this could be a confounder because, as you know, the sicker patients with diabetes are going to be the ones who are going to end up on insulin. And so it may be a confounding, sort of a marker of more severe disease. But again, the conclusion or the recommendation from the American Heart Association is in patients with heart failure, you try to use other agents such as metformin and SGLT2 inhibitors if adequate glycemic control can be achieved without insulin. Then the thiazolidinedione drugs like pioglitazone and rosiglitazone you have all heard of. There are randomized controlled trials actually that have demonstrated that TZDs are associated with increased rates of heart failure hospitalization in patients that do not have heart failure at baseline. The main issue with these drugs is fluid retention, and hence they are not recommended in patients with established heart failure, and you have to use it in caution in patients who have diabetes without heart failure, but they may have other risk factors for developing heart failure down the line. So what about the newer class of drugs like GLP-1 receptor agonists? Well, there are some important secondary effects of these drugs. They decrease appetite and food intake, which leads to about a 2 to 4 kilogram weight loss. They improve lipid levels, they decrease triglyceride levels, and they increase HDL levels. Cardiovascular outcome trials have shown in these drugs that they do improve cardiovascular outcomes, but really don't have any impact on heart failure hospitalization, which is the nature of our talk today. So this is a FIGHT study, was a study that was done on patients who were admitted with acute decompensated heart failure, and they were randomized to either liraglutide versus placebo. And they showed that there was no impact in terms of reducing heart failure hospitalization or death related to heart failure, as you can see in this slide here. What about DPP-4 inhibitors, like all the gliptins that Dr. Hamilton also hinted towards? Well, there's no evidence that DPP-4 inhibitors provide cardiovascular benefit. In patients with diabetes at a high cardiovascular risk, some DPP-4 inhibitors, in fact, actually increase the risk for hospitalization for heart failure. So with established heart failure, it is basically you should use caution when using these drugs. So this is the trial, that SAVOR-TIMI 53 trial, that showed actually increased risk of heart failure hospitalization in patients who were at high risk for heart failure hospitalization. The SGLT2 inhibitors, Dr. Hamilton has talked in detail. I just want to skip this just for a moment and give you this synopsis slide of the major outcome trials in the 3 major classes of newer classes of drugs. And just to give you a background, that this was mandated by FDA in 2008, that no longer will the new drug trials focus on glycemic control and outcomes, but more importantly, cardiovascular safety outcomes should be the priority. So MACE events, the typical way that we do cardiovascular trials, was what was studied in these classes of drugs. So blue, as you know, are the GLP-1 agonists. And then red, you have the DPP-4 agonists, and then DPP-4 inhibitors, and then SGLT2 inhibitors. So for major cardiovascular events, yes, there was a decrease in major cardiovascular events, but it was all primarily related to heart failure hospitalization and cardiovascular death. So what I'm trying to say is none of these drugs actually decrease the risk of MI or stroke. None of these classes of drugs actually decrease the composite. They decreased the composite, but it was predominantly driven by cardiovascular death and heart failure, reducing heart failure hospitalization in the arm of SGLT2 inhibitors. GLP-1 receptor agonists decreased MACE by decreasing cardiovascular death predominantly. And DPP-4 inhibitors really didn't have any outcome on MACE, and in fact increased heart failure hospitalizations. So this is a synopsis slide to give you some idea of the new classes of cardiovascular drugs and what you can anticipate when your patients with heart failure are on these medications. So with this, I want to set the stage for, and then one more comment I would like to make before we get into the SGLT2 inhibitors, is that when you look at the cardiovascular outcome trials of SGLT2 inhibitors, and you stratify them, and this is what the trial that did this was the DELIVER-TIMI 58 trial. And what this did was that they, at an enrollment, substratified patients into, based on ejection fraction, 45% cutoff, into HFrEF, as you can see here, or HFpEF. And you can see that when you look at HFpEF as an entity, the cardiovascular benefit was muffled. And in fact, the most of the benefit was in patients with heart failure with reduced ejection fraction. And that held true both for hospitalization for heart failure as well as cardiovascular death. So in summary, if you look at the diabetes guidelines and you try to merge them with the patients who have heart failure that our cardiologists, as we cardiologists are taking care of, you will probably want to go metformin is first-line therapy. Now, despite metformin, if the glycemic control is not adequate, and if ACVD predominates, like cardiovascular risk factor for CAD predominate, you can either use a GLP-1 receptor agonist or an SGLT2 inhibitor. If, however, CKD or heart failure predominates, based on the data that Dr. Hamilton went over, it's preferable to add on an SGLT2 inhibitor. So that was a checklist, but with that, I think we should now get into some of the trial data and talk about some of the mechanisms of how this drug, that is actually an anti-diabetic drug, has now given us some leeway into understanding more pathophysiology as it can work for patients with heart failure alone. So with that, I was going to read out to my panel if you have some comments, and I will have some slides as well. But what are some of your thoughts, Dr. Hamilton and Dr. Bhimaraj, about the mechanistic insights into how these drugs might be working?
Yeah, no, that was a very nice summary. Because I think that we're going to find that there's niches and roles for, especially the incretin agents, GLP-1 mimetics in particular, and SGLT2s, but maybe in little different classes. Earlier on, GLP-1s, they might reduce events, and but with heart failure, there's not quite as strong a data as with the SGLT2s.
Yes. Except,
at least in preclinical work, and there's some clinical work too, that maybe in HIF-PIF, where there's an early diastolic dysfunction, the GLP-1 agonist may have a benefit. And of course, in our lab, we isolate mitochondria and study attend that there's a slight mitochondrial improvement in ATP production, and we've done actually down to cardiomyocytes that we've isolated. And if you even decrease the ATP production just slightly, systole will persist, but diastole is affected. Diastole requires ATP too, but the Km of the enzyme is such that a slight drop in it, all of a sudden you can lose diastolic relaxation, but you can still continue contracting. And there's some evidence, not that we've done, but presented some of the meetings I've been to, that the GLP-1 agonists might help at that situation. So if you have somebody in early heart failure symptoms, but with preserved ejection fraction, considering GLP-1 agonists. On the other hand, it's clear in individuals with heart failure, metformin is favorable, but they got its caution if the kidney function declines, if the eGFR gets below 30. But then adding the SGLT2 inhibitors, it may be a class effect, but especially the ones that have most of the data. And monitoring them, but if all of a sudden renal function is declining, or especially if they have some component of diastolic dysfunction or significant fibrosis there, the addition, you don't have to use one or the other, the addition of the two may be favorable.
Sure.
So mechanistically, there's some, still we don't understand the effects, and it's not just normalizing the blood sugar and treating the diabetes.
That's right.
That's why I even I hesitate to use the term diabetes drugs, because I'm beginning to think that especially the SGLT2 inhibitors,
they're not.
They're not. They may be cardiovascular drugs, and I think that's why I wanted to emphasize for cardiologists. I know just our hallway conversation of just the challenge of what one should we use, what are the doses, what do we have to monitor.
Yes. It's
not that complicated. Now the GLP-1 agonists are injections, but they're still easy to prescribe. It's once a week, comes in a pen device, and whether you have diabetes or not, you can take it. And
so Dr. Hamilton, you in the list that Imad talked about and the preference of medications, you notice that metformin doesn't have much evidence, insulin neither. As these new medications that are showing such a big CV benefit are coming up, do you foresee that these will become the primary medications for diabetes, and I guess I'm leading into the question, are they as good as an anti-diabetic medicines to lower the blood sugars and HbA1c, that we should probably get rid of metformin and then just use these new class of medications?
Yeah, not get rid of metformin. It's got a lot of other benefits too. Beta cell preservation, gradually with type 2 diabetes, the beta cells fighting this insulin resistance. They're like an oxen carrying a heavy cart. Pretty soon they just start dying out. It preserves the beta cells. There's some advantages there with lipid care. Diabetologists, because I think when these new trials come out, and we've got a couple more, probably at this upcoming European cardiology meeting, and then there's a couple of large trials that next year will be coming out, showing that even if you don't have diabetes, use of these medicines, so that we don't need to be in the loop.
Right.
And so I think they're going to become cardiovascular medications.
Yeah, I think practically that's something which is coming up in practice, where we're prescribing medicines which don't have to be diabetic medicines, because they're showing benefit, the DAPA, HF especially.
Totally independent.
And how do you, but at the same time, how do you create a system where we work in synergy with the endocrinologists, so we're together treating the entity? And I think that's where systems need to be created in my mind. And in our institution, as we were talking earlier, I think we're beginning to sit down and figure out, if I see a patient and I want to prescribe DAPA, how do we have an institutional protocol and agreeing on certain things? So I think that's probably where it'll evolve in cardiologists getting comfortable in prescribing these medicines, but at the same time not complicating the care for diabetes, because you don't want to change medications that have an impact on another disease without interacting with them, right? That's the complexity of the system.
It's going to require some collaborative teams, because there's, just in our own institution, there's probably, 90 or 110 cardiologists here, and 8 endocrinologists that are doing clinical work, or there's more than 8, maybe 10 or 12. The volumes of it we couldn't handle, but if you had some dedicated people to, especially with heart failure, of course this has been an interest of mine, I mean we go back quite a ways on that, it's a new area, and I think even in the diabetes field we're seeing more and more people that get interested, kind of like cardiologists, they go through their fellowships and then they might get interested in heart failure versus interventional cardiology or imaging.
I want to remind our viewers too that they can send in questions. So I think as we're coming to the later part, we'll continue some more discussions, but you can send in your questions. That's on the screen, by the mechanism to send it in, pollev.com, or you can text to 37607. So feel free to send in your questions that we can answer, and as they come through, we'll engage the panelists and have a discussion. But Dr. Hussain, as you were asking the mechanism of action, I think as the name speaks, the sodium glucose transporter, and how in the kidneys the blocking of this is promoting natriuresis along with the glucose being let go and instead of getting reabsorbed. I guess one of the mechanisms is kind of what we're believing is just diuresis and less sodium, renin-angiotensin, but I think there's more to that, and the data is limited, but maybe you can talk about and tell us, do these receptors exist in the heart, and is there in the heart that the sodium glucose receptors are making a change in how we are?
Yes, no, absolutely. Thank you for the question, Dr. Bhimaraj. So, just to kind of get into, I think the best trial that has given us mechanistic insights into how these drugs work is the DAPA-HF trial to date, although the Emperor reduced trial is going to be published, like Dr. Hamilton said, they're going to discuss their data at the European Society of Cardiology meeting. But if you look at the DAPA heart failure, in very simple terms, DAPA looked at, it didn't really matter whether you had diabetes or no diabetes, the benefit was very similar. So off the bat, one thing it's telling you is that treating hyperglycemia is not the mechanism by which these drugs are working. But in order to get into it a little bit more, I would like to give you some background. So if you look at the initial outcome trials of SGLT2 inhibitors looking at prevention of heart failure, not patients who had established heart failure, those trials either did not report neurohormonal modulation, or if they did report neurohormonal modulation, it was very, very minimal. Very few people were on heart failure-directed medical therapy because that was not the purpose of the trial. It was a cardiovascular safety trial. But if you look at the magnitude of benefit in prevention of heart failure, was a 30% reduction, relative risk reduction in hospitalization for heart failure or cardiovascular death, which was the actually primary outcome of the DAPA-HF trial. Now, in the DAPA-HF trial, you have patients that are on very good neurohormonal medications. As a matter of fact, very high grade use of guideline-directed medical therapy because these are patients with established heart failure. And now you see that the magnitude of benefit is exactly the same. It's similar. It's the same whether you use neurohormonal antagonists in the background or not. So what am I trying to say here? Well, what I'm trying to say here is that there's something called drug interactions. So if there is a drug interaction, then your magnitude of benefit is less. But if there is no drug interaction, then your magnitude of benefit is not less. So in other words, what I'm getting at is that it is highly unlikely, based on the DAPA-HF trial and keeping into account the historical trials in SGLT2 inhibitors, that neurohormonal modulation is a mechanism by which dapagliflozin is working. If that were the case, then its benefit would have been muffled on the background of neurohormonal therapy. Right? That's the first point I wanted to make. Now, the second point that I want to get into in terms of the mechanistic insights is what Dr. Bhimaraj hinted towards. So I would like to show you this slide here. If you look on the left, so one of the effects of SGLT2 inhibitors is that it causes afferent arteriolar constriction. And once it causes afferent arteriolar constriction, it reduces, initially a response to that will be reduced GFR. But then beyond that, it is very protective in chronic kidney disease, so it prevents further progression of chronic kidney disease. And for us cardiologists, you can think of this reminiscent of RAS antagonists. As you know, prior to this, ACE inhibitors and ARBs were very renal protective in terms of preventing further progression of chronic kidney disease. So definitely, like Dr. Bhimaraj said, that cardiorenal interaction is definitely likely be playing a role here in terms of, as you all know, that worsening renal function is one of the major prognostic factors in heart failure. So if you're able to mitigate this worsening progression of CKD by using SGLT2 inhibitors, this cardiorenal, and have a favorable cardiorenal interaction, the chances are you may affect prognosis in a positive way. Now, there is this theory, it was a very interesting theory that it just recently came out, and I would like to share with you, which in terms of mechanistic insights, and then we'll stop for questions. SGLT2 inhibitors, as you know, the way they work is they reduce sodium reabsorption, reduce glucose reabsorption in the proximal renal tubule. As a result, they cause glucoseuria. So in other words, it's creating a state of nutrient deprivation in the blood. And then that result, nutrient deprivation, caused signaling of various cardioprotective hormones. Okay, one of them is the SIRT1. It's been very well studied, actually. And downstream effects of this are basically it improves mitochondrial function. It is the reason why there is increased erythropoiesis and ketogenesis in SGLT2 inhibitors. This is well documented in trials. It also results in reduced serum uric acid, and as you all know, uric acid is an marker of oxidative stress. By reducing that, it can reduce oxidative stress. And the other thing that it activates is AMPK. Now, I want to tell you this because this is very important. I talked to you about drug interactions. Well, metformin also activates AMPK and has its downstream effects in terms of cardioprotection. So if you look at the cardiovascular outcome trials, and if you adjust for metformin use, the 30% relative risk reduction in cardiovascular was muffled. It went down to, say, 15% if you were concomitantly on metformin. This is telling you that there may be a drug interaction in a way that metformin and SGLT inhibitors may be working in the same way. So what I'm getting at is that this is a plausible theory. because this is not talking about neurohormonal modulation. This is talking about nutrient deprivation signaling, and then the cardiorenal interactions. And putting these two together may be a hypothesis that may pan out in the future trials in terms of mechanism of how these drugs are having favorable beneficial effects, both in terms of cardioprotection, but also in terms of renal protection. So that's kind of a little bit of a brief summary or a hypothesis that I think might be playing a role here.
Yeah, very, very interesting.
Yeah, I think it's the fascinating part which you highlighted in your talk is that the need to look at CV outcomes was created because FDA was worried about the adverse effects of some of these anti-diabetic medications. And I can only imagine the early investigators when you were trying to avoid harm and then suddenly you're seeing this enormous benefit,
yes,
which was unexpected. So
unexpected.
I think this area, as you have alluded, it came out of the blue, so there's a lot more to discover. So
absolutely.
I think it's a fascinating field moving forward. So it looks like we have some questions, so maybe I think Dr. Hussain, you can tackle this, but we have a question saying, as in your experience as heart failure specialists, do you notice de-escalation of antihypertensive or diuretic doses once patients with heart failure are started on SGLT2 inhibitor therapy? So I think, Imad, in your practice, what do you do?
Okay, so I think answers, yes. So I think that's a very, very good question, actually. So the thing is that, like I said, in the current scenario, unless there's a practice update, because what we need is we need some guidance, because we have now 2 trials, additional medications in the form of the Victoria HF trial, which we haven't talked about today, the Vericiguat, and the DAPA HF trial, which is dapagliflozin. These are new armamentarium of drugs in the heart failure spectrum. But generally speaking, we still have patients on Entresto, and people who are who are on background of Entresto. Now, people who are familiar with Entresto dosing, they do understand that at times they have to cut the diuretic dose when they're starting Entresto. So most of my patients, unless they cannot tolerate it for blood pressure issues, are on background of Entresto. In that context, when you are adding dapagliflozin, my general initial strategy is to slightly cut the diuretics and then assess the response. And it's not like I just leave them and then they're seeing them after 3 months. I bring them back in 2 to 4 weeks, repeat labs, redo physical examination, and then if the diuretics need adjustment, we can adjust them back forward. But initially, I do advise slightly cutting down on diuretics because of the osmotic diuresis that you see with SGLT2 inhibitors.
Yeah, I think that's a very practical question, and it makes sense. And if you think about it, in general, in principles for heart failure care, diuretics have never shown long-term benefit.
Yes.
So if you have to cut them, I think those are the first medicines that we reach out to. And in that regard, maybe you can give a practical guide of when are you thinking about DAPA in these patients? You know, where patients now have ACE inhibitors, beta blockers, or ARNIs, aldactone, Vericiguat has come out. So, you know, we've coined this term, not pharmacological toxicity, but it's coming to financial toxicity.
Yes.
So how do you add it? And also to acknowledge that in the DAPA trial, only 25% of the patients were on Entresto.
Yes.
So if you have a patient in front of you and it's a new diagnosis,
yes,
when do you think of DAPA?
Yes, I mean the current guidelines are not in the sense that heart failure guidelines, but the current FDA approval is for patients with HFrEF that have persistent symptoms despite and elevated serum NT-proBNP despite being on GDMT, which is current GDMT. So that would include a beta blocker, ACE inhibitor, or ARB, or ARNI, plus an MRA, and if there's any device therapy indicated. So on top of that will be when you would consider dapagliflozin for persistent symptoms of heart failure. That's currently how we're practicing this.
And I think one last question, we're coming up on the hour, and probably have more of an endocrinology focus, Dr. Hamilton. When we're prescribing these medications, say we have a common patient and you've been managing diabetes, and they come to me first because they haven't seen you in a little while, now we have DAPA. If I want to start DAPA, what would you expect from me? Do you expect us to call you so we have a discussion, or are you comfortable letting cardiologists start it and then when you come back you can guide them? What do you want the world of cardiology to walk away from how we should prescribe these?
Yeah. I would be very disappointed if you did not start it, whether you talk to me or one of my colleagues or not. Start it. And then if they have diabetes, of course, we can then adjust other medicines if we need to or that. But the benefits on heart failure are becoming so pronounced. To not start it would be a problem. I would start it. It'd be good to notify us, but I think at least, but sometimes there's hurdles in it, you know.
No, I think
if you had to wait for a consult to come up and they were in the hospital for a day or two longer, and just start it, and we can follow them up as an outpatient, or just notify us electronically. And if we know the patient, we'll pick up.
It's a very good point that you brought up, Dr. Hamilton. I think that in terms of starting the medication, at least in our acute decompensated heart failure patients, because when they're kind of they have tenuous renal function, the volume stat, they're almost on the volume depleted state, completely dried out by the time we're ready to discharge them from the hospital, and we have been typically waiting to see them as in there are outpatient visits to try and initiate this medication. But do you think this is something should be even initiated inpatient, or what are your thoughts about this?
Well, I would think initiated inpatient. Now, of course, we don't have standards on it yet, and I'm just speaking, you know, just from my own personal view on it. But I think starting it as an inpatient, and so you can at least observe it for a day or two, because the initial thing is not going to be the impact on the blood sugar. It's not like starting insulin or a medicine that's going to drive the blood sugar down. It's one that's going to impact the volume, which is something that you guys monitor on a regular basis and have to adjust, you know, like that initial question, maybe the diuretics or that.
This is a very good point.
I would like to think we would get involved with all of them, but just the manpower situation and doing it, and the especially, I would start it.
I think that's actually a valid point. If when we look at trials and say, oh, this was all an outpatient trial, I think there has to be some discussion. Even though the trial did not study inpatients, the reason not to start things inpatient are more safety issues. And to your point, it actually makes sense to start them inpatient because you can monitor them and the volume status. Most of the patients who get admitted is because of volume.
Yeah.
So I think this are very good practical pointers, and I'm glad you mentioned that you'll be disappointed if I don't start it. And that's one of the barriers where I think we have to remind ourselves as cardiologists, putting patient at the center and not saying, oh, let me ask the endocrinologist to start it, but take the initiative, start it, and then make the effort to send a message so we can follow up and work together. That's a very, very important point to make.
There could be complicating factors. If they're on a sulfonylurea class of medicines we don't use much anymore, at least in the diabetes and endocrine field. If they're on one of those, you might have to stop it, reduce it, or adjust it. Then you might want to get at least a phone consult or something, or we could see them if they're in the house. But to start it as part of a heart failure treatment, if they've got mild diabetes, of course, there's a lot of complexities, but to not start it maybe do more harm on the patient than good.
Yeah, absolutely. I think I think the era has come for diabetocardiology, and we've had a very good discussion. And thank you, Dr. Hussain and Dr. Hamilton, for this wonderful overview. There's more to come. This field is moving very fast, and I hope your lab, your research, and in our clinical world, and we all can identify novel mechanisms and then hopefully contribute to the field. With that, I think I want to remind all of you again to watch out for the Heart Failure Hour, for our group to focus on various topics of heart failure, the intersections of diabetes, intersections of interventional world, EP. So please tune in on a monthly basis, and thank you very much. You have a good evening.
Thank you.
Thank you.